to start with a little bit with the diagnosis of multiple myeloma because some things have changed, especially over the past couple of years. It's not only just the different check boxes we check to say this is myeloma or not, but the way that has changed has also reflects how much has changed about how we think about this disease and when do we need to actually do something about the disease. And we will talk a little bit more about smoldering myeloma later on in the afternoon session, but I just want to kind of start or create the setting for that discussion later on by talking about how the diagnostic criteria has changed. So this was, I don't believe it's almost 3 years now since this particular publication came out, where the International Myeloma Working Group, which is a collection of close to 200 myeloma experts from across the world, and we developed a lot of these guidelines which are used in the clinic for various things like diagnosis, the prognostication we are going to be talking about later, and so forth. So when you talk about myeloma, it's really the tip of the iceberg. There's a whole large group of diseases which are all characterized by some of these abnormal plasma cells. Plasma cells is to create antibodies to fight infections. That's their primary responsibility. But something goes wrong in these plasma cells and they start dividing without any control, and that is the underlying basis for development of multiple myeloma. So presence of these abnormal plasma cells and the protein that these cells make, which is referred to as the monoclonal protein, which I'm sure when you go into the clinic, you always talk about the M spike or the free light chain. So these are the two characteristics of, or at least the basic requirements for making the diagnosis. Now, I just want to briefly talk about how do we detect these proteins, right? So we always, I'm sure you all hear about the serum protein electrophoresis when you go into the clinic. And what it essentially does is take the protein in your blood, or the blood sample that you give is run on what we call a gel electrophoresis, and this is what it looks like when you run it across the gel. All these proteins separate, and this particular M spike or the monoclonal protein you typically tend to see in this particular lane, and the height of that or the concentration or the density of that band tells you how much of the M spike or M protein is there in the blood. Now you can do the same thing in the urine and in the blood, and that's how the urine or the serum protein electrophoresis tells you how much of the M spike that a particular person or patient has. But that only gives you a quantity. It doesn't tell you what type of M spike or M protein you have. And that we do additional testing, what we call immunofixation. So they use antibodies against the different types of the M protein. And depending upon where these bands live, we can decide, okay, this patient has a G type of M spike or heavy, what we call the heavy chain. And there's also a light chain component or piece to the monoclonal protein, which can either be a kappa denoted by K here or lambda shown in L here. So by doing more sophisticated testing, we can tell you the M spike is a G kappa in this particular instance, or it could be a G lambda, or it could be a kappa. I've heard those terminologies in the clinic, and we want to know what type of M spike a person has. It has some implications as to how the disease might behave. But about 1 in 5 patients actually may not have anything detectable by these two testing. And those are the patients whom we call as having light chain myeloma. And those patients, what happens is they only have these kappa light chain or the lambda light chain. They don't make these what we call the heavy chains, the G or the A or the M. And for those patients, the vast majority of them, the only way we can quantitate or measure the M spike is to do something called serum free light chain assay. And using, and I won't go into the details of the assay, but that assay can tell us how much of kappa light chain is there in the blood or how much of lambda light chain is there in the blood. So these tests all in all allows us to detect an M spike or a monoclonal protein in about 97% of patients. There's still about 2 to 3% of patients who don't make any protein at all. And those are the patients who are often, we talk about non-secretory myeloma. Fairly uncommon, 2 to 3%, but they do exist. The other half of the story is to show that there's actually these myeloma cells sitting somewhere. And the most easy place to find them is in the bone marrow. Okay, so you all have had bone marrow biopsies or bone marrow aspirations. And this is what it looks like when you look at under the microscope. You can see these cells. Here's a myeloma cell with two, what we call nucleus. Here's all myeloma cells. They all have this characteristic shape. And by looking at the microscope, we can clearly identify them. But bone marrow is not the only place where you can find these myeloma cells. You can also find them in the blood. The vast majority of the patients have at least a few myeloma cells in the blood, but only a small proportion of patients will have significant numbers of these myeloma cells in the blood. And that also has implications for how aggressive the disease is, and we will talk about it in a couple of slides later. Now, some of you may have had what your doctors may have referred to as plasmacytomas. Okay, so this can occur in right next to a bone. It can occur in a soft tissue, like in any of the organs. These are generally collections of myeloma cells. If you do a biopsy, all you see is packs, and they're basically packed with myeloma cells in there. Now, so there are different ways to get at these myeloma cells to demonstrate or show that they are there. Now, what has changed with respect to how we diagnose myeloma? Now, in the past, we had to have that monoclonal protein. We often had to demonstrate that there's monoclonal plasma cells or these myeloma cells. But we also wanted to show that these are actually doing something bad to the person. And the typical things we look for is high levels of calcium, something affecting the bone, which typically means usually there are little holes that are punched out holes in the bones, or the bone might become weak enough to fracture. Patients are often anemic, so the hemoglobin goes down. And they could have problems with their kidneys. It could vary anywhere from mild malfunction of the kidney to kidneys completely being shut down. But what has changed in the recent past is, with the new diagnostic criteria, is that we don't always have to wait for some of these bad things to happen. If there are things that tells us a particular person has a very high likelihood of these things happen, then we don't necessarily need to wait for the other shoe to drop, so to speak, before we start the treatment. So what are these markers? So if you do a bone marrow biopsy and you find that there are lots and lots of plasma cells, over 60%, we are fairly sure that these, even though in the past we used to call these people as having smoldering multiple myeloma, now we know those patients or people would have myeloma develop very soon. So now we don't wait anymore to start treatment. Similarly, the free light chain, or if you have something on the MRI scan. So as I said in the beginning, it's not just that we are able to start treatment on a few more patients early. It is also it's a big change fundamentally in the way we think about myeloma. Now, we have gone from a place where we wouldn't start treatment until something bad happened to a place where we are going to start treatment because we are pretty sure something bad is going to happen. And that, I think, reflects a big change in how we think about myeloma. So with that as a background, I'm going to talk a little bit about what, the high-risk myeloma, which again, as Jenny already mentioned, is a major focus for the field. And I think that is one place where we have not made a significant progress, despite having made significant progress in myeloma overall. So maybe I'll take a quick break there and see if there are any burning questions before I move on to that.
That last part, you were saying that they're trying to find it sooner.
Right.
What kind of a test is run, though? Is that run like a regular doc? I mean, why would you get that test?
Right, so that's a very good question. So, some of those things we would do anyway, right? So smoldering myeloma patients, we always do, or we suspect smoldering myeloma, we always do a bone marrow biopsy. So this first thing here is just a question of acting on that information slightly differently. Okay. But the second one, the PET or the MRI scan, is not necessarily something we always used to do in the past if somebody had smoldering myeloma. Now that has become part of that testing that we do. So we do the imaging or the scan, and based on the results, now we start treatment, which we wouldn't have done in the past. That is really new, and that is right. So the blood test here would be the free light chain and the bone marrow, both of which we always did in the past. It's just that the information is used in a different fashion. All right, so we'll move on to how we risk stratify these patients, right? So one of the very first questions we always ask, not just myeloma, in any cancer, are there things about what we know today that can predict tomorrow, right? And that is essentially the basis of risk stratification or risk assessment. We know that patients with myeloma are living longer and longer with the new treatments we have, but unfortunately we still have a fair number of patients where myeloma becomes very resistant to treatment very early on, and it becomes very, very difficult to control. Now, the question is, how can we identify the patients on day one instead of having to look back and say, yes, this was a bad myeloma. Now, there are clearly tools that we have developed, but there's clearly more things that we need to understand as well. So I will go over some of those things. Dr. Fonseca is going to go over the genetic part of it in more detail, but I will kind of set the stage for what that means. But suffice to say, there are things about the myeloma, there are things about the patient, and there are things that reflects what the myeloma has done to the patient. They all factor into how the myeloma is going to behave. So one of the simplest things that have been used for a long time is something called an international staging system. The reason why this was so widely used was because it was very simple. All it needed was 2 blood tests, something called serum beta-2 microglobulin and serum albumin, and just based on those 2 numbers, we could predict to some extent how the myeloma would do. But that is a very crude tool because it didn't really tell us which way to treat the patient, except that it kind of gave us a peek into the crystal ball. So what has really changed, I think, myeloma is the presence of different genetic abnormalities. As we started looking more and more deeply into these myeloma cells by using more sophisticated testing, especially a test called FISH, which you'll hear more about later on, we can get a better sense of what is happening in the chromosomes in these myeloma cells. What we have found is that almost every patient with myeloma, there would be some abnormality in the myeloma cells. Now, when you think about them, there are 3 major groups of abnormalities. One of them is called translocations. What happens is a piece of, one chromosome goes and gets itself attached to another chromosome, and they kind of exchange the genetic material, so to speak. So those are translocations, and you can find some translocation in almost 40% of patients with myeloma. Now, another 40 to 45% of patients can have what we call trisomies. What happens there is one of the chromosomes, there are 3 copies instead of 2 copies of every one of the 26 chromosomes that we have, right? So 23 chromosome sets that we have. So what happens here is, for example, in this particular patient, there's 3 copies of chromosome 13. So here you see that it's a trisomy of chromosome 13. The third set of abnormalities that we see is called deletions, and that what happens there is you basically lose a piece of the chromosome. And all these things can overlap. Most patients can have one or more than one type of abnormalities. Now, what do these abnormalities, what is the implications of having these abnormalities? So, depending upon what type of chromosomal abnormalities a patient has, we can categorize them as what we call standard risk, intermediate risk, or high risk abnormality. Again, what we mean by high risk is that this myeloma is more likely to behave in an aggressive fashion. It's more likely to become refractory to treatment sooner. It's more likely to relapse after treatment sooner. So high risk are the patients with what we call deletion 17p, where they have lost a piece of the chromosome 17, or this translocation 14, 16, 14, 20. Abnormalities like the 414 or the amplification, having more than 2 copies of the 1q, that is also, shows a relatively more aggressive type of myeloma. So what has happened is that we took that simple ISS staging system and combined that with this high-risk genetic abnormalities and came up with a new classification called Revised International Staging System. So the 2 simple blood tests we talked about, another blood test called LDH, and then this FISH testing in the bone marrow. So 3 blood tests and a bone marrow test will give you a good sense of how this a person's myeloma is going to behave going forward. So very valuable information, not just in terms of how to predict how the disease would behave, but also give us some insight into how that particular myeloma should be treated. And you'll hear more about that once we get to the treatment part. But we're continuing to see what are the other markers or what are the other red flags that could be there which would make us do something differently. Okay? So one of the tests that have become available is what we call a gene expression profiling. So this is essentially, again, bone marrow myeloma cells. We take them, subject them to a specific genomic testing to see how much the genes are active. And based on which all genes are more active, we can actually identify groups of patients who may not do as well as others. And there's a whole bunch of different, what we call genetic signatures that are being developed. You may have heard about some of those tests like MyPRS. There's also something new from Skyline Diagnostics that's coming through. So all these, the major goal here is, can we be more sure about when we say this is high-risk myeloma or this is standard-risk myeloma? Because the test, like the FISH test, does give you a crude way of looking at it, but it's not a very specific, meaning that if you cannot always be 100% sure if you say somebody is high risk, that person is indeed high risk. So we're trying to develop other markers to give us much more refined system of looking at this question. Now, more recently, we have been able to look for what we call mutations. So instead of losing big parts or pieces of chromosomes, these are abnormalities just within a gene. So that gene doesn't function well. Either they become more active or they become less active. And based on these different mutations, now we have a better sense. Now we probably have maybe a couple thousand patients with myeloma who have the tumor genome sequenced. And based on the presence of these different mutations, we can identify patients who may not do as well or may not respond to a particular therapy. Or we may be able to identify a patient who is likely to respond very well to a particular therapy. So that's kind of the personalization of therapy that's going on now, or that we will see in the future. Now, another marker is how fast the myeloma cells divide. Now, especially many of the patients who have been seen at Mayo Clinic, this is a test that we do commonly in the bone marrow. And it also gives us some information. So if you see that, typically we see less than 1% of these myeloma cells in the bone marrow are actively dividing. Now, if you were to find that 5% or 10% of them is actively dividing, that often makes us worried, and we want to think about it as something that could be more aggressive.